Serious, military docs. What are some interesting differences between military and civilian medicine? Army surgeons in early days of Iraq got quoted in it saying major diff between military and civilian patients is the troops are in perfect health up until the moment they are injured in combat. It makes for easy, almost textbook perfect surgeries. Nobody has other chronic problems that would complicate matters. Other thing they mentioned was that if they requested medical equipment, it was flown in 36 hours later. No questions asked. They'd never seen operating rooms with so much redundant equipment. All of it state of the art. No need to delay for a few hours a medical procedure until a facility or piece of equipment was available. Medics learn a lot of stuff on the job that they would never be allowed to do on civilian streets. Suturing, injections, etc. I'm Vietnam era and rotated through several hospitals in Germany. Doctors were happy to teach. Oh, and I helped with several deliveries. Traditionally, military dentists can work freaking voodoo magic with amalgam for dental work. In the civilian world we just use resin composite, the tooth colored stuff, with a bonding agent. The reason I say voodoo is that amalgam silver fillings don't actually bond to anything. It's held in with physical friction and structure. You have to drill the tooth a certain way to make sure it doesn't fall out, and I've seen some work on veterans that are over 20 years old and I have no idea how they made it stay in place in the first place. I found the opposite. I'm currently several $1,000s into fixing the questionable dental work I was forced to get in the military. They wanted to replace a couple of childhood fillings I had. Somehow I ended up needing surgery to repair my jaw, 4 caps, and 2 root canals. There is no confidentiality, or rather, it is very limited. If a patient tells you they used drugs, or did something against regulations that impacts performance, you're obligated to report it. But it's more than that. I haven't been on a military base for some time, but back in the day it was common for people to check the online scheduling system, via CHCS, to see which co-workers had appointments with certain doctors. Unlike Epic, there was no record kept of these searches. So what would happen is a boss or clique at work would treat a person differently all of a sudden, and it would be a sign that they checked CHCS. It's not fair, but in the military, being active duty and seeing a shrink is not viewed compassionately. It led to a lot of resentment to us in the mental health clinics, which I can totally understand. We were trying to help, but even stepping foot in our office would endanger their career. To be fair, administration would do what they could, but ultimately changing the culture and the computer programs takes a lot of time and effort. The patient population tends to be much younger and healthier. The flip side is that they tend to be much more reckless, so self-destructive behavior like smoking and engaging in risk-taking activities is rampant. There also tend to be either massive overutilizers or underutilizers of healthcare. The overutilizers go in for minor aches and pains because there's no co-pay and it will get them out of work or certain aspects of their duties they find undesirable. The underutilizers are the young men and women who try and tough things out or fear consequences if they seek medical care, so they tend to avoid docs. Another huge aspect of military medicine is the career implications you can impose on someone as a doctor. In civilian practice, there's little issue of giving someone a diagnosis. However, putting certain diagnoses in a service member's record can be a career killer. Imagine being in 17 years, 3 years from retirement. Then some doc puts fibromyalgia in your chart and now all of a sudden you're being looked at for medical separation. Medical was underutilized on the ships I was on because the solution to anything wrong with you was to get put up in your rack for a day and drink lots of fluids. So now you're stuck in your rack all day but you still feel like crap and nothing was actually done to solve the issue. It depends on if you are in garrison, on base in your home country, or deployed. In garrison, medical procedures are rather complementary to civilian counterparts. It is when you are deployed that you have a more carte blanche method of medicine. I was a 20-year-old corpsman doing chest tubes and pericardial synthesis, pericardiocentesis, Tyudochavok, on Marines and civilians in Iraq with no doctor supervision. However, in those cases it is purely about stabilizing the patient so they can make it to the next level echelon of care. As a former soldier who knew quite a few medics, I'm going to just assume it was both. When you find a person who you need to help, according to military medicine, they put check for massive bleedings first. But in civilian medicine we check for clear airways first, because in the civilian life the chances for having something down your throat is more likely than being shot and bleeding out. I was a combat medic who did urgent care after the army. The biggest change to me was demographic. Treating solely athletic young males can make you blind to sign symptoms, and treatments that might be dangerous to people of more variant sex and age. One example is you can cause neurological damage to an older person if you infuse them too quickly with an IV. Something to so with hypertonicity and damaging myelin, which can be reduced in the elderly, or that smaller people are more prone to air embolism from a quick and dirty IV that would be harmless to a soldier. Medics are trained mostly to stop bleeding and trauma, but you also pick up plenty of non-emergent stuff along the way working for PAS and physicians. Most procedural stuff I got yelled at for doing wrong when I first moved to clinical from military. I later found out from a former EMT, now physician, wasn't wrong, but more commonly seen by EMTs. Do hire a former medic though, because they are very versatile and usually can handle not only EMT, clinical, and lab-based work, but also the logistical stuff like supply and management, because in the military all of those jobs are filled with medic. Oh, except receptionist. Didn't know crap about how medical insurance worked when I first got out. My dad was stationed in Texas for his military service as an orthopedic. He said every now and then someone from the special forces would come in, presumably from South America somewhere, and he would drop everything to do surgery on them first. There would be no paperwork whatsoever, and then the person would be shipped back out. Also, military doctors receive a heck of a lot more respect than civilian docs. Respect thing is probably BC when deployed you only got this one doc to help you while you can just go to another hospital in civil. They're more protected from medical maltreatment or whatever it's called. Ol' Private Jimmy can't sue the doc if stuff goes wrong. Interesting, I work in the UK myself and rarely see malpractice suits, although I hear it's much commoner in the private sector. The thing is, there are so many safeguards that doctors use to make sure they are on the right side of the law. Most of the ones on the news are just examples of gross negligence. I'm not a doctor, but I'm a career submariner. The docs on US submarines are not actual doctors but independent duty corpsmen. They attend a 1-year school that's basically a crash course. They learn 2 years of medical school in that year. Once the sub departs at E6 or E7 is the only guy capable of keeping the crew alive should something happen. I've seen them do some amazing stuff. They are truly the unsung heroes of the sub force. I got told this by a friend who was submarine officer. He said Navy put its best corpsmen on subs, with the fuck ups getting assigned to the Marines. I'm a civilian EMT, but in the National Guard I'm an MP. In Army Basic they teach every PVT regardless of their MOS how to do interventions like the needle chest decompression, something myself and my colleagues are unable to legally do in the civilian world until we are at least paramedic level. Yep, I was a clerk typist, but I learned how to bandage a sucking chest wound in basic training. I used to be a doc before transitioning to a civilian urgent care. What acceptable levels of clean are? When I got trained on IVs, the doc teaching me literally held it in his mouth while situating everything. Gloves are a good part of medicine too, but it's more of a suggestion in the military. Also, the amount of expired meds we carry around is ridiculous. We very rarely get new stuff, and so you're supposed to make it last. In our defense though, needles don't really get less sharp with age, but still. I watched a sergeant spit on an NPA to jam it down a guy's nose. Yesterday, in a civilian hospital, I watched staff throw out a whole heap of meds because they were a day out of date. Your priority in a combat zone footage is to figure out who can still shoot. When you place someone with trauma to their lower limbs on a litter, leave their arms unrestricted. Just because your legs don't work doesn't mean you can't fire at downrange. My dad knew a dentist in the military who said it was boring as heck. It was all young healthy men who'd already had any major problems fixed, so he just ended up doing a lot of fillings. He quit the military when he could just so he could do more interesting civilian cases. Medics also have a few specialties. I was an Army medic orthopedic specialist. The scope of practice and experience is dependent on how knowledgeable and competent the surgeons feel you are. On deployment it was essentially no holds bar as far as what procedures we were allowed to do. A benefit to no insurance or liability. This included actual surgery on wounded and routine cases on active duty military personnel. Yes, that is cutting and suturing under the watch of the surgeons. It is a little hard for me to remember, but as other people have stated, we were definitely doing things that would only be done by a physician in the States. You can have immense responsibility as a E5 sergeant if you are up for the task. That includes being responsible for ordering and fitting millions of dollars of equipment, striker, der oil, casting supplies, etc. You can be the casting clinical supervisor, and when the orthopedic clinic supervisor goes on leave you're in charge of that as well. Other responsibilities can include key custodian, MSDS book, making sure everything is sanitary, JCAHO compliance, etc. Basically jobs that would be done by multiple people in the civilian world done by one soldier. You can also side train and work with prosthetics, physical therapy, and occupational therapy to ensure the continuity of care. The surgeons I worked with in the military were great, including hospitals and clinics in Germany, Walter Reed, and Brooke Army Medical Center. On a side note, the VA care I get is amazing. Frontline triage is backward from civilian life. If someone with a broken pinky and another person with a sucking chest wound come through the door at the same time, we're fixing the broken pinky first. That way you can hand him his gun and send him back out the door to win the fight, lest we all become casualties. It's back to normal once you're away from combat, but in the heat of battle the immediate concern is to get people back into action as soon as possible. My dad was an ophthalmologist in the Air Force. He mentioned how there was a big difference between the civilian practice and military, mostly the culture of it all. It was doctor, last name, not major, last name. As a military doc you're normally treated like a civilian more than any other officer, and you get big bonuses for retention. It's because it's more cost effective to pay bonuses to the less common medical specialties to stay in and work, when they are paid 2-3x less than a civilian counterpart, than to send patients off base and deal with trickier paperwork. The payoff is the preparation though. Typically you come out of a commitment without school debt, especially if you hit 20 years. You can say things bluntly to your patients like, look sucker, of course you're not getting better because you're doing nothing I freaking told you to. As some people have stated, a major difference is that certain diagnoses can change your entire career. However, I personally never saw anyone's career ended by a diagnosis. I saw many people unable to get a proper diagnosis because it would end their career. I worked on a submarine and the nuclear weapons personnel and nuclear engineering personnel had some of the most strict medical requirements in the military. Additionally, their communities were all critically undermanned fleet-wide. The only treatment any of them ever received for anything not life-threatening was megadoses of ibuprofen. Fractures, second-degree burns, torn ligaments, a panoply of dermatological problems. Here's a bucket of ibuprofen. Non-nuclear personnel with the same problems would receive much more thorough treatment, and civilians with the same problems would receive much more thorough treatment. I work in an inpatient ward on a military base. Coming into the Air Force I had no idea we even had those. I take care of older veterans. I wipe butts, help feed, bathe, and dress them. I sometimes forget I'm even in the military since I only wear scrubs. Sometimes we get younger active duty patients, but they are usually there to recover from surgery. In the Air Force all of the enlisted medical technicians are EMT certified, yet they can work anywhere from a ward, a clinic, or front desk. Martrin and water cures everything in the US Army. Headache? Drink water, take Martrin. Sick? Drink lots of water, take Martrin. Twisted your ankle? Here's a bunch of Martrin. Now go drink some water. Gunshot wound? Apply Martrin directly to GSW and then pour water on top. Same for the Navy Marines. On the emergency trauma side, tourniquets are a huge no-no for civilians. For medics and corpsmen, a tourniquet is often the very first intervention. Wife was a military clinical doc and is now civilian. In the military, Her department had 8 doctors and 2 nurses. Sometimes one of the nurses would be deployed, so there would be 1 nurse for 8 doctors. In civilian practice, each doctor has their own nurse. In the military, rank was sometimes more important than ability. She had occasions where a high-ranking patient would want someone else to see him, since she was only a captain. Never mind that the colonel he ended up seeing spent most of his time doing administration, and saw very few patients. I think the biggest difference is that in military medicine people will come in for the smallest things, stuff that they could handle on their own with just a little common sense. And every time we say something about it, it's always the same response. Why would I pay for it? I'm only an E-nothing. I don't have money to spend on meds. Listen buddy, if you can't buy $4 worth of Dayquil, you seriously need to reevaluate your budget. We also couldn't just call in sick. We had to go to medical. Army BH provider here. Having worked both in and out of the active duty hospital setting and field environment, and done internships in the civilian world, the biggest difference I'd say is accountability for quality of care. In my opinion, in the civilian world, because of how insurance works, your doctor has financial incentive to want you to like them. You're a consumer. You can, theoretically, take your money elsewhere. In the military, you get what you get. Don't like me? Too bad. File a nice complaint to make yourself feel better. Unless I break the law or provide some type of unethical treatment, neither me nor my civilian counterparts are going anywhere. Other than the fact that I truly give a crap about my patients, I have zero motivation to provide anything outside of the bare minimum of standard of care. I want to do right by you. You're the reason I come to work every day. Your hurt drives me to be better, to do better. And one day, between meeting my army obligations and additional duties, on top of the sheer number of patients I see in a day, and the administrative bulls and sheer amount of time I spend writing an 18-page note in your medical record, I might burn out. And I hope to God that at that moment I have the insight to see that I'm starting to fail you and I do us both a favor and drop my refrad packet. Or maybe I won't notice and I'll become that typical army provider y'all are angry at having to come to see, that pushes pills and says see you next month and you file that ICE complaint that no one will actually give a crap about. I could do whatever was deemed necessary to a military personnel. Civilian side, I had a license, and I could get it revoked, fined, or possibly even go to prison if I performed an intervention that was not on my license, even if it worked. Also military is HABC. Army medic and now civilian nurse. Scope of practice is a big one. In military medicine for the most part you can do what you know how to do, so the scope gets pretty wide if you put work in and learn stuff. In civilian medicine your scope is pretty strictly what your license certifications are. As an army medic I could, and did, do IVs, intubation, NG tubes, push all sorts of IV drugs, etc. In civilian medicine a ton of that is paramedic RN, even MD level, so you can't touch it unless that's what you are. Mom having me in the Air Force, saluted the doctor, was in the hospital 4 weeks with preeclampsia and still had to get up every day and make her bed. Mean nurses. Mom having my sister after the Air Force, everything done for her, no making the bed. Nurses were nicer. The only people that do good shoulder instability surgery are military orthopods and sports medicine fellowship trained surgeons. My dad said he went from opening up people in shape to opening up obese people. He said the military was much less work. Haha. The scope of practice for non-doctor medical folks. As a civilian I am only an EMTB, barely qualified to drive an ambulance. As an army medic I have assisted in chest tube insertion and removal, emergency trauma surgeries. I can carry and administer major narcotics and basically anything that my medical practitioner says I can do. The ability to operate fairly independently in the field is something you won't see as much outside of the military. This probably won't even get seen, but from a patient standpoint, one difference I know of firsthand is military docs pick and choose what they want their patients to know. I took my husband to Omaka while he was still active duty because he thought he was having a heart attack. We find out it's a really bad anxiety attack after he gets an EKG and nothing is physically wrong with him. Fast forward 3-4 years and I'm going through his medical documents after he's been discharged because he's now in heart failure, and I find the EKG from that visit. clearly listed is the 2 heart diseases he's recently been diagnosed with by a civilian doctor. My husband's heart failure and even possibly his open heart surgery could have been avoided if the army docs had told him what was going on and didn't put his body through so much physical and emotion stress that his heart couldn't handle. He's now 100% disabled and doesn't trust doctors at all. I worked labor and delivery early in my Navy corpsman career. Now that I'm out, I am no longer in medicine. So this'll be a bit more of what I've heard about the civilian world of labor and delivery. But I've seen posts about people getting charged for skin-to-skin contact after birth and other ridiculous things. In the Navy, as long as everything was okay, we encouraged it. I also really focused on getting the dad involved and making it a great experience memory. For example, helping me clean the newborn, getting prints, showing him how to make a newborn burrito, etc. To me it seems that we had a lot more freedom. In the civilian world it seems that there are price tags attached to everything. If you work civilian labor and delivery, let me know if I'm wrong. Another thing I've experienced and I imagine is not acceptable in the civilian world is how we get to practice. It wasn't uncommon to find a room full of corpsmen practicing IVs or blood draws randomly. Docs and nurses also let us try things that were probably a bit outside our scope, which was always awesome and helped us become more well-rounded. I think the military patience we have also makes it easier to be allowed to practice and learn. Very rarely did I bring a new guy in and have a patient lose their mind and demand someone more experienced. More often than not, they either encouraged the trainee or teased them with me as they were nervously trying to find a vein. As a purveyor of military medical services for the last 18 years and counting, I can say almost for sure that military doctors care more about ensuring you can deploy than they do your actual health. I literally have to lie my butt off symptom-wise to get anything more than Motrin and to take a few days off from doing that thing that bothers you speech. I could have cancer or who knows what else. I will never know unless I see actual doctors. If you are new to the channel, you can subscribe. I publish new videos every day. Until then, check another video. Bye for now.